Okay, this is Lab 6 review, going over the wrist, palm of the hand, and the joints, upper extremity, which we'll get to last. Just like the last videos, we're going to start by taking a look at the brachial plexus. Again, remember, we're dealing with the ends of the brachial plexus, the musculocutaneous nerve, which we know is going to innervate the anterior part of the arm, the axillary nerve, which is our deltoids and our teres minor, our radial nerve, which is going to be the posterior compartment of the arm muscles and the forearm. Then we have our median nerve, which today so median nerve is the anterior part of the forearm, with the exception of 1.5 muscles, the flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus. Both of those are going to be innervated by the ulnar nerve. But specifically today, we're going to be looking at the median nerve as it innervates the hand. So the thenar compartment, and then the second and third lumbrical. And then we'll be looking at the ulnar nerve, which we said was, again, part of the anterior part of the forearm. And then specifically, the ulnar nerve is doing most of the innervation of the hands, as we'll look at the hypothenar compartment, which is, again, our pinky compartment. We're going to be looking at the interosseous muscles, which we have a nice pad and dab, mnemonic, lumbricals 4 and 5, and then the adductor pollicis. All right, so we also, just as a quick reiteration of previous video, we have been, for this exam, talking about the muscles of the forearm. And so why bring these up again? Well, we have the tendons for these muscles are going to be going into our hand. And so for the posterior forearm, remember, so the back of the forearm, we said that that is going to be innervated by the radial nerve. And so our mnemonic for the posterior forearm was beer lifting, breakdancing muscles unless atrophied, going from brachiobrachialis to the extensors. Again, posterior forearm, we're dealing with extensors, right? You imagine going to the gym, how you're moving your arms, you're flexing, you're doing a curl, you're dealing with your interior forearm, your flexors. But in the posterior part, you're dealing with your extensors, so breakdance, beer lifting, breakdancing muscles unless atrophied, brachiobrachialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, and then the aconius. And then deep to that, we have our not quite as good mnemonic, super thumb index with our supinator. The thumb on the posterior forearm is going to have 3 muscles, the extensor pollicis longus, extensor pollicis brevis, and abductor pollicis longus. Remember, we said that pollicis means thumb in Latin. And then for index, we have the extensor indicius for the index finger. All right, on the anterior forearm muscles, we have our superficial mnemonic is pass, fail, from the lateral side to the medial side. And the first one, pass, is our pronator teres, fail is our flexor carpi radialis, pass is palmaris longus, and then fail is flexor carpi ulnaris. On our intermediate layer, we didn't have a good mnemonic, but we have our flexor digitorum superficialis. We really like this muscle. Why? Because it deals with flexing our 4 digits. All right, and then deep to that, we have our punching muscles. And you think, how are you going to punch somebody? You curl in your 4 fingers, you curl in your thumb, and then you turn over your wrist. And so the first one, curling in your 4 fingers, is your flexor digitorum profundus, which is deep to the superficialis, but is also connecting to our 4 digits. Okay, and then we have our flexor pollicis longus, another thumb muscle, and then our pronator quadratus, which is twisting our wrist. All right, so that's, this is old stuff, but today we're looking at the hand in particular. And so we have 3 different compartments of the hands. And the way we remember this is we draw a little Triforce, and our Triforce, if you're a fan of Nintendo and Zelda, has 3 compartments and 3 parts to it. So the Triforce, if you're holding the Triforce in your hand, you have 3 compartments in your hand. You have the thenar compartment, then you have the middle compartment, and then you have the hypothenar, which is our pinky compartment. All right, and so each of these compartments, just like the Triforce, has 3 muscles in it, and then we have a sort of an extra muscle which doesn't fit this mnemonic quite well, but that's the palmaris brevis, which is located right here, palmaris brevis. All right, so starting with our thenar compartment, we got 3 muscles, and our mnemonic is 1 for all, starting with the opponens pollicis, which is going to be deep to our other 2 muscles, our flexor pollicis brevis, our abductor pollicis brevis, and then our middle compartment, again, we have 3 muscles. We have our adductor pollicis, so the most superficial. We have our lumbricals, which in Latin means worms, and so the lumbricals are kind of weird because they're originating on the tendons of the flexor digitorum profundus. Okay, and then we have our palmar interossi muscles and our dorsal interossi muscles, and so we use the mnemonic. We'll go over it a little bit more later, but pads for the palmaris. The palmar interossi muscles, pads, is going to be adducting our fingers, which you can see is like bringing your fingers in towards the center of your hand, and then dabs for your dorsal interossi muscles, which are bringing your fingers, it's abducting them out. And so, if we just quickly look at the these muscles, so first we have here the lumbricals highlighted, and you can see that they're originating on the tendons of the flexor digitorum profundus, right? It's kind of weird. So they're these worms, lumbricals, worms in Latin, and then you can see that they're inserting on the phalanges overall. Okay, so that's not that exciting, but let's go ahead and hide those. All right, and then here we have our interossi muscles, and if we take a look at them sort of from this view here, you can see that one is dorsal or anterior to the others, right? And so you're going to highlight the dorsal ones, right? So that's a dorsal one. Over here's another dorsal one. Look over here, dorsal, and let's see. Well, I think you get the picture. But the palmar ones are anterior, and the dorsal ones are posterior on the hand. Okay, and you can see their insertions along the metacarpals, and their origins along the metacarpals, and then their insertions along the phalanges. All right, so just back to our page. So that's our middle compartment. Then we have our hypothenar compartment, which is our pinky compartment, thenar referring to the thumb region. And this is, we had 1 for all, now we have all for 1. So basically it's the same type of muscles, but for the pinky. We have the abductor digiti minimi, flexor digiti minimi, opponens digiti minimi, which is, again, the deepest, just like the opponens pollicis was the deepest on the thenar compartment. All right, and then for taking a look at the innervation, our mnemonic is half, loaf, half. And so basically the ulnar nerve is going to be doing most of the innervation in the hand, but half of the lumbricals, so half loaf, L, is going to be from the median nerve. Then you have the opponens pollicis, abductor pollicis, and the flexor pollicis brevis. And so these are all from the thenar compartment, which if we go back to what we had said previously, the median nerve is going to be all of the anterior forearm except for 1.5 muscles, and it's going to be the thenar compartment. And we see that this is held true. and half of the lumbricals. And so that means that everything else is the ulnar, innervated by the ulnar nerve. And notice how we said half of lumbricals, we didn't mention the interosseous muscles, and so that means that the interosseous are innervated by the ulnars. All right, and then one more thing before we delve into the slides, we have the bones of the hand. We, of course, have our phalanges out here. We notice how the thumb only has 2 instead of 3 for the other fingers. We have our metacarpals, and then we have our carpals. And you notice that there's quite a few carpals. Our metacarpals are labeled, just with nice numbers, thumb being 1. But our carpals, you kind of look at this and it's a little bit intimidating. So we have this nice mnemonic, which is so long to pinky, here comes the thumb. So when I first read that, that was pretty funny. Anyways, so if we go ahead and we look at the if we go ahead and break that down, so we have, starting with S, we have scaphoid for so, then you have L for lunate, then you have 2 for triquetrum, then you have P for pisiform, then you have my favorite, which is hamate. Why? Because it's just fun to say, hamate. And then you have, after hamate, you have capitate. Right, so that's here comes, and then you have our trapezoid, and you have our trapezium. All right, and then we know that our carpals, if you were to look at them down the length of the hand, would make our carpal tunnel, and then over that we have the flexor reticulum, which goes over the top. This is a fibrous membrane that holds everything in, and of course on the inside we have our tendons from the flexor digitorum superficialis and our flexor digitorum profundus, and then we also have the median nerve pass through the carpal tunnel. All right, so can you describe the structures of the superficial palm? All right, so if you look at the palm, we have our palmaris longus tendon, and we would call that it sort of flattens out and becomes the palmar aponeurosis, which just means flattened tendon. All right, we have the palmaris brevis. This was the sort of one-off muscle that we said didn't quite fit into our nice Triforce mnemonic for the 3 different compartments of hands, each with 3 different muscles. All right, then we have the recurrent branch of the median nerve, and then we, of course, we're thinking about our thenar region, our hypothenar region, and then our middle region of the hand. All right, so if we reflect back the palmar aponeurosis, which again is just a flattened tendon of the palmaris brevis, if we reflect that back, we can see all of these different structures, notably starting with the ulnar nerve and the artery right here. And if we just go ahead and trace that along, let's start with the artery. So we trace it along, and you can see that we have this arterial arch that eventually feeds back into the radial artery. Okay, and then we have the palmar arteries that are coming off of this arch and providing blood to each of our digits. Okay, then we have the nerve. So we have the ulnar nerve. All right, we have our median nerve coming in here, going through the carpal tunnel. Okay, and our transverse carpal ligament. Okay, and then if we were to take a look at this image, we can see the palmar digital arteries, our ulnar artery coming in, and then a radial artery coming in on the side of the thumb, and we can see that they're kind of eventually meeting back up. All right, if you were to cut open the carpal tunnel, you'll see a variety of different tendons going through. I think it's written on the next page, but we have the flexor digitorum profundus, flexor digitorum superficialis, right? This makes a lot of sense. The muscles in your forearm are what are allowing your fingers to flex. If you curl your fingers into a fist, how are they doing that? Well, you have to have the tendons from your forearm come through, and to pack them in nicely, keep things organized. Our body is giving us this nice carpal tunnel, and all of these tendons are passing through, and then specifically only the median of the nerves, right? We have the radial nerve in this region, we have the ulnar nerve in this region, and we have the medial nerve in this region. Only the median nerve is going through the carpal tunnel. All right. Can you describe the function of the median nerve? All right, as a hand, and then the muscles of the thenar compartment. We already kind of went over this. So all for one: opponens pollicis, flexor pollicis brevis, abductor pollicis brevis. And so you can see the median nerve here. It's innervating. We talked about in the previous lab. The median nerve innervating the dorsum, part of the dorsum of the hand, specifically right here, the front of the hand, and then the tips of these fingers on the back of the hand, and then part of the thumb as well. And then we have, of course, we know the median nerve is half of the lumbricals, right? We saw the lumbricals are worm-like muscles attaching to the tendons of the flexor digitorum profundus tendons. So you can kind of see them here. These lumbricals, 1 and 2, are going to be from the median nerve. And then we also have the muscles in the thenar compartments, our flexor pollicis brevis, our adductor pollicis brevis, and our opponens pollicis are going to be our thenar compartment muscles. And we said that the flexor pollicis brevis is actually going to be partially innervated by the ulnar nerve as well. All right, we can't see the opponens in this image because it is deep to these 2 muscles. Okay, so can you describe thumb movement? Oh boy, and the related muscles involved. So we have seen a lot of muscles involved in the movement of the thumb, starting with the flexion and extension. If we start with the extension of the thumb, we have in the deep anterior forearm, we have the extensor pollicis longus, and then we also have the extensor pollicis brevis. Because it's anterior forearm, we know that that's the median nerve. That's going to do that. And then if we're talking about flexion of the thumb, we have the flexor pollicis brevis in the thenar compartment, and then we have the flexor pollicis longus, and then those are going to be doing flexion overall. And so what does this look like? Well, if you look at your, facing your palm, and staring at your palm, which is the most interesting thing to do. But if you were to bring your thumb towards the center of your palm, that's flexion. If you bring your thumb outwards, that is extension, okay? And then if we were to look at the back of our palm for the next one, abduction and adduction, for abduction, moving away, right, that'd be pushing your thumb forward. If you're looking at the back of your palm this time, pushing your thumb forward, that's abduction, and then pulling your thumb back to the plane of your hand, if you're looking at the back of your hand, that is adduction. All right, and so we have in the deep anterior forearm, we have the abductor pollicis longus, we have the abductor pollicis brevis in the thenar compartment, and then in the middle of the hand, we have the adductor pollicis, which is innervated by the ulnar nerve. All right, and then finally for what does opposition of the thumb look like? This is just, you take your thumb, you're touching each of your fingers. That would be opposition, and we have in the thenar compartment, remember, one for all for one, the opponent's pollicis. All right, the course of the ulnar nerve, we are really getting to it, but we said that the ulnar nerve is doing most of the innervation of the hand. So if we talk about the superficial ulnar nerve is going to go to the dorsum, the skin of our hand. And we said that, remember, trace the bones in our hand, right? On this side, we have the ulna, and so our ulnar nerve is traveling along there, and it innervates the last 2 digits of the skin of our hand. And then we have and of course it shares this one with the median nerve. We have the hypothenar, the pinky compartment, the interosseous muscles, these 2 lumbricals. Then we have half of the flexor pollicis brevis. And so what does it innervate? So written it out here, but can we see all of the muscles of the thenar compartment? The answer is no. The opponents, we have one for all. The opponents flexor, or the opponent's digiti minimi is deep to the other 2 muscles in our hypothenar compartment. All right, so can you identify the lumbrical muscles in the intermediate palm? Again, here they are right here. And we said that the lumbricals means worm in Latin, so it's attached to the tendons of the flexor digitorum profundus and inserts along the metacarpals. Okay, and then how do lumbricals promote flexion of the MP joints and extension of the IP joints? So notice how they are inserting by the dorsal hood. And so the idea is if this is your fingers extended outwards, if you were to contract the lumbricals, it's going to flex the fingers, but it's also going to pull on the dorsal hood such that the IP joints, which are further out, are going to be extended, right? Sort of pulling the dorsal hood. The finger itself the overall finger is going to flex inwards, but pulling on the hood is going to cause the other joint to extend outwards. Okay, the adductor pollicis muscle is right here. We know it's innervated by the ulnar nerve. Interosseous muscles we talked about, they're right here, and also innervated by the ulnar nerve. Okay, then we looked at adduction versus abduction of the fingers, and we have adduction is going towards the center line, and abduction is going to be the exact opposite. We have our mnemonic pad for our palmar interosseous muscles, which is what we're going to be doing this movement, the adduction, but pad, so P-A-D, and you use P-A-D, palmar adduction, right? So bring the fingers in. Okay, and then the opposite is true for the dorsal interosseous muscles. Remember we said the dorsal interosseous muscles are just ever so slightly behind the, dorsal interosseous muscles are right here, so different color, right here, and they're ever so slightly behind the palmar interosseous muscles. And when I say behind, I mean posterior to, dorsal to. So our mnemonic is dab, and that's just dorsal abduction. It's going to be abducting from the center line of our fingers, and we know that the innervation, of course, is the ulnar nerves. All right, let's see. We kind of already touched this. What happens if the ulnar nerve is injured? Well, we know that the ulnar nerve innervates 1.5 muscles of the anterior forearm. So that's the flexor carpi ulnaris, and then the hand muscles. We have the and then flexor carpi ulnaris, and then 1/2 of the flexor digitorum profundus. And so basically, if this is injured, we know that this is innervating parts of the skin, so you have loss of sensation on the skin, and then you'll have a loss of motor function to flexing the hand, and really that's it overall. And then being able to spread your hand. All right, so here we see loss of sensory information from the skin on the front to the back, and then difficulty with spreading our hands apart due to loss of innervation of the lumbar muscles. And so where are the most common sites of ulnar nerve injury? Well, if you're talking about the arm/forearm, it's at the funny bone, which is our medial epicondyle, right? Our favorite bone, our favorite epicondyle of the humerus, right? Because it's a bigger one, and that's our funny bone. And the ulnar nerve travels along there, and so that's a good common place to you can hit the funny bone. It's not fun. And then here you have this area right here is the Guyon tunnel, which is another common place of injuring the ulnar nerve. All right, so same thing, discussion with the median nerve. We know that the median nerve is doing most of the innervation of the anterior forearm, and the anterior forearm is mostly flexing, right? So you have, just like we're talking about with the ulnar nerve, the median nerve, you're going to have a loss of flexion. Then you have the median nerve is doing most of the innervation for the thumb, so you'll be able to control your thumb very well. And then loss of sensation in the dorsum of the hand. Most common site of injury for the median nerve is the carpal tunnel, right? As we have the median nerve goes through the carpal tunnel. So if you hurt your wrist or inflammation from overuse, then the median nerve is often pushed against and hurt. All right, lumbricals and interosseous muscles. We have our dorsal or extensor hood. Our lumbricals are inserting along there, and then we have our interosseous muscles. And oh my goodness, I'm so sorry. I think going back to this, our interosseous muscles are causing our abduction and our adduction. And I think I said earlier that the lumbricals are doing that. Okay, and so let's just moving on. Yeah, so we have our lumbricals are inserting up here near our distal to our extensor hoods, and then our dorsal interosseous muscles inserting on our extensor hood. Okay, and I think that's just about it. Ligaments of the shoulder region are actually not too bad because you just really need to know the structures of the bones, and if you can label the different parts, then you can know what the ligaments are named. And so here we have the acromion, and then we have the coracoid process, and so the ligament between those two are the coracoacromial ligament. And then here we have the clavicle. Right, up here we have the clavicle, and then we have the acromion process. So this is the coracoid process. This is the coracoclavicular ligament, not too bad. And then here we have the superior transverse scapular ligament, and this is the subscapular notch. If you remember from the previous lab review, we said that the suprascapular artery and nerve, which are innervating and supplying the supraspinatus and infraspinatus, are going to be traveling through here, and we have the mnemonic army over, right? So the artery is going to go over the superior transverse scapular ligament, and the navy suprascapular nerve is going to go under. All right, then we have our transverse humeral ligament right here, which is going to go from our greater tubercle to our lesser tubercle. And moving on, same thing over here. Transverse humeral ligament, we have our coracohumeral ligament, so from the humerus to the coracoid process. And then we have our superior glenohumeral ligament, so this is our superior glenoid tubercle, and then the humerus. And then over here we have the middle glenohumeral ligament, so we are in the middle of the glenoid cavity, and we're on the humerus over here. All right, so not too bad. It's really just knowing the different parts of the bone, and then just basically mashing together those two words. All right, long-headed biceps brachii, we all know this. This is supraglenoid tubercle. And then here we have the radial collateral ligament with the radius from the end of the humerus to the radius, so the radial collateral ligament. And then over here we have the ulnar collateral ligament, and so just remembering the word collateral is really the challenge here. And then the annular ligament is going from the ulna to the radius. Again, just a little bit of memorization work. We have the fat pads along the end of the humerus. And during the radiology session, we talked about it as being an indicator of pathology. If you have a break in this region, typically the fat pads will be a little bit separated from the structure, and so that would be a good sign that there's inflammation and break in the region, or some sort of pathology. All right, intermediate and distal radial-ulnar joints. All right, so up here we have radial-ulnar joint, that would be more intermediate, and then down here is our distal radial-ulnar joint. We have our articulation disc here. What does it do? It stabilizes the joints and transmits force. We have our radial collateral ligament and our ulnar collateral ligament. All right, and so then remember we also have our radial collateral ligament up here and ulnar collateral ligament down there, and so same name but different spots. All right, and I think that's it. So that's the end of this particular lab review. Good job. We will take a quick look at the surgical case, and then we'll call it a day. So that's lab 6. All right, so we're just going to go over this surgical case scenario really quickly. Bill's a 58-year-old male presenting for pain in his right wrist. He describes the pain is tingling along with some numbness. His worse at night. He also notes some associated weakness in his wrist. He has no history of diabetes and no prior surgical history. He worked a desk job for over 30 years and noted that his roles included frequent typing. On physical examination, there's some tenderness to palpation along the volar aspect of the right wrist. Both Durkin's and Tunnel's tests are positive. There seems to be some atrophying of the thenar musculature in the right hand. EMG was ordered, and there was also median nerve conduction velocities that are less than 50 meters per second across the carpal tunnel, which is highly suggestive of the carpal tunnel syndrome. The patient has tried steroid injections and splinting, but they're ineffective, thus he's presenting today for endoscopic carpal tunnel release surgery. All right, median nerve is irritated in the carpal tunnel syndrome. What are the actions the muscles innervated by the median nerve? So the median nerve is mostly responsible for the anterior forearm, and then the thenar compartment of the arm. So flexion and opposition, or thenar compartment of the hand, which would be the thumb. So flexion and opposition of the thumb, we know that it is going to be innervating the half of the flexor digitorum profundus. So that's the flexion of digits 2 and 3, and then flexion and abduction of the wrist, and then forearm pronation. What tendons are found in the carpal tunnel? One must be careful not to injure these tendons during a release procedure. So we have the tendons of the flexor digitorum superficialis, the flexor digitorum profundus, and the flexor pollicis longus. All right, that's it. We're done with lab 6. Good job.